Hi, everybody. Welcome back. This is chapter 17. We're going to be talking about disorders and immunity in this chapter. That includes things like autoimmune disorders. These are our learning outcomes for those of you who are wanting to test your knowledge and make sure that you're learning what you're supposed to in this chapter. All right. Immunopathology is a term that is referring to the study of disease states associated with overreactive or underreactive immune responses. By overreactive, we're talking about allergy, hypersensitivity, and autoimmunity. And as far as hyposensitivity is talking about, we are talking about the immune function being incompletely developed, suppressed or destroyed. So it's just not working. There's some step in there that isn't working at its strongest the way that it is expected to. So these ones are also called immunodeficiencies. This is just comparing what we're going to be talking about today. We're actually going to start off with talking about the hypersensitivities, and then we'll be moving on later to the hyposensitivities. Hypersensitivity antigens will be eliciting that hyperreactive response. They can be exogenous or endogenous. Exogenous, of course, being from outside the body. That could be like food, microbes that you're overreacting to, pollen, all that sort of stuff. And then we have endogenous things that you could be reacting to. And most of the time, we're almost exclusively talking about autoimmunities here. The four main categories that we're going to go through, the sensitivity types, type 1, 2, 3, and 4. And type 1 will be common allergies and anaphylaxis that we typically think of with allergies. And then we have IgG and IgM mediated cell damage in type 2. We're going to be talking about primarily blood type mismatching. And then type 3, immune complex formation, which again, we'll talk about when we get there. It'll make more sense what we're saying. And then type 4 will be delayed type hypersensitivity. It's dependent on that T cell response, that cell-mediated response. So it's going to take a little bit longer for the response there. So this is just a breakdown of all of those hypersensitivities and the types, and getting down as far as the systems and the mechanisms that are involved in causing those. And we're going to get into these now. So starting with type 1 allergic reactions, these are going to be our allergies. There'll be exaggerated immune response to some sort of specific antigen that we shouldn't be having that sort of response to. And it'll be manifested by inflammation. And we'll consider something an allergy if you are having that type of reaction to something where most people do not. So that is how they would compare it. Hypersensitivity these are going to technically be delayed reactions because your first time seeing them, you have to develop the IgE against that antigen thing that you're allergic to, but then every time after that you'll react very quickly in response. So it does require sensitization, as they say. Yes, so once you have been sensitized and you do have those antibodies, you will have immediate onset upon exposure to these things, and it'll be associated with exposure to specific antigens, so like ragweed or something. Levels of type 1 allergy severity, we have atopy, so that's going to be localized, and it is chronic because you'll have it recurring. So that would be hay fever and stuff like that. So it is localized. And asthma, please remember that it's still part of just the respiratory system. It doesn't affect every other part of your body. So this is also just a localized situation. So it is atopic. Now, anaphylaxis is going to be systemic and sometimes fatal if it is not controlled, where we have airway obstruction and circulatory collapse in response to this. Okay, so nearly half of the US population is affected by airborne allergens. That's no surprising thing. We do have genetics as part of the component, but it seems to be the next slide is probably going to explain a little bit better, but yeah, so it does seem to be genetically related, but it's not always predictable by genetics. There seems to be more involved in it. And one of those things that they think is involved in it is the hygiene hypothesis, This is suggesting that our immune systems need to be trained by interaction with microbes in our environment so that we can learn how to properly react to things. And that in the industrialized world, in the first world, we no longer get exposed to these things. It's too hygienic. And so there seems to be a correlation with this, that if you are been delivered by cesarean section, you are actually 8 times more likely to develop a food allergy. And they believe this is because, according to this theory, that this is because the baby would not be exposed to the vaginal and the stool bacteria that it normally would be due to vaginal birth. That's what their theory is. Allergens. I would know about the different portals of entry and be able to recognize which one belongs to what portal, right? So if I were to ask you guys, what's the portal of entry for pollen, then you guys would know that it's an inhalant. Okay, so be aware of these. And I'm not going to go through the whole list, but most of them are pretty straightforward. But I would be aware of the fact that bee venom or wasp venom falls under injectant. This is just basically showing type 1 response and walking us through it. You see your first time you're seeing your dose that you're going to be allergic to. Let's say it's pollen. First time you're seeing it, it'll come in, our lymphatic vessel will carry it to a lymph node. And then in the lymph, the B cell will recognize the allergen as foreign with a little bit of triggering from the T helper cell, right? We talked about that, it needs to be activated. The B cell proliferates and differentiates into plasma cells, making IgE antibody, eventually switching classes to that. The IgE then binds to receptors on the surface of mast cells. Okay, so these guys are coming back. So they bind on the surface of mast cells, and then as they interact on those IgEs with the allergen, now that allows the mast cells to decide to degranulate, and that'll result in the reaction that we see with allergies. Mast cells are everywhere. We see concentrations in the lung, the skin, gastrointestinal, and genitourinary locations. They bind with IgE during sensitization and degranulate during this time. So you can have reaction due to that once we have enough IgE to react with the, what is this? With the actual mast cell. So, right. I don't know what else to say about it. Yeah. So it binds with IgE. The allergen would, once it's bound on the mast cell, the IgE will interact with that allergen, and then that leads to degranulation of that mast cell. That's how this whole process will be working. So the IgE prime mast cell remain in tissues for years and can react in those tissues as soon as it sees a thing, pretty much immediately, and then that will stimulate degranulation of those mast cells in those areas pretty much immediately, right? All right, let's continue. So the chemical mediators will be released into the tissues in the bloodstream, and those will lead to the symptoms of allergy. This will be due, so whenever you have symptoms of allergy, it's not from the allergen, it's not from pet dander, it's not from the, okay, so chemical mediators will be released into the tissue and go through the bloodstream, and the symptoms that you see from an allergy are not due to the actual allergen itself, but in fact due to the effects of the chemicals that are released by the mast cell in response to them. So, okay, so these are our primary chemical mediators involved in the allergic reactions. So yeah, here you go. And then in this next slide, we talks a little bit about what you would see due to effect from each of these chemical mediators. So whether it's dilated blood vessels or constricted bronchioles from prostaglandins, even headache development due to effects on nerves. We have dilated blood vessels. Over here as well, due to the histamine, serotonin, and bradykinin, we have diarrhea and intestinal response, and then secretory glands, mucus production. And we'll have constriction of bronchioles and mucus build up in the airways due to the leukotriene production. So all those chemicals, that's the effect that they're going to have during that type 1 response, due to a lot of the response by the mast cells. So atopic diseases, again, these are going to be local. These are going to include hay fever and asthma. So hay fever is also known as allergic rhinitis. So allergic, allergies, rhino, nose, okay? This is a seasonal reaction to inhaled things, and it'll be chronic and year-round due to just the presence of when that allergen is around. And then we have asthma, which is characterized by impaired breathing and bronchoconstriction. We often have reactions to inhalants, foods, and infectious agents as well. It's also possible. So then we have eczema. This is an atopic dermatitis. So atopic being localized, dermatitis being inflammation in the skin. So here you can actually have sensitization through inhalation and ingestion. And sometimes the skin contact, but you notice I'm saying sometimes the skin contact because it's mostly the other two. This will begin in infancy with reddened vesicular weeping and crusted lesions. Then we have progress from childhood into adulthood involving dry, scaly, and thickened skin. Food allergies, most commonly we see this with peanuts, fish, cow's milk, wheat, eggs, shellfish, and soybeans. Portal of entry will be intestinal and ingestion, right? But it can also have effects on not just the intestinal system, but skin and the respiratory tract. So intestinal, we'll see vomiting, diarrhea, and abdominal pain, but outside of that, you can still see development of eczema, hives, rhinitis, asthma, and occasionally even anaphylaxis due to food allergies. Drug allergies, usually a mild rash. Sometimes you have fatal anaphylaxis that will develop as well, depending on the medication and the person's response to it. So this includes antibiotics like penicillin and sulfa drugs, which are also antimicrobials. Then we have aspirin and its derivatives, opiates, and contrast dyes used in x-rays. So we can also talk about the systemic anaphylaxis. This is going to be a sudden respiratory and circulatory disruption. This can be fatal within minutes. It's often due to injections, but not always. So the allergen and route of entry will be variable. But we do see this with bee stings often, and we do see this with injections of antibiotics that you might be allergic to or serum exposure. So sensitivity can last for decades once you've been exposed. Those mast cells associated with this really hang out. So we diagnose this by in vivo methods like looking for atopic and anaphylactic sensitivities, putting it on the skin, whether we inject it under the skin or scratch it into the skin or prick it, depends on what method you're using. And then the allergist will map on the skin and the inner forearms to see the response and determine after 15 minutes if you are allergic to the thing that they're looking at, putting in your skin or on your skin. All right, to treat your allergies, there is treatment with anti-allergy medication that can block progress of the allergic response. And then we have the oral anti-inflammatory drugs themselves. So this will be activity of inhibiting the activity of the lymphocytes and the production of the IgE at that point. So these can have significant side effects, so we don't want to take them for prolonged periods of time. We can also take antihistamines, which are quite effective. They prevent the symptoms of the atopic allergy. The active ingredients in most over-the-counter allergy control drugs are going to be falling in this category, in antihistamine, right? Trying to control allergies, antihistamine, we relate that pretty well. These will interfere with the histamine activity by binding to histamine receptors on target organs. Okay, epinephrine, also known as adrenaline, it's the same thing. These will be used in the case of anaphylactic attacks to try to reverse that constriction of the airways, open airways back up so you can breathe again. It'll slow the release of the allergic mediators involved. It has a very short life, however, so you're gonna, it'll buy you time to get to the hospital, but don't think that because you used your EpiPen and you feel better that you're good to go home, because when it wears off, you could be in serious danger. So we can desensitize some allergic patients, will benefit from controlled injections of that antigen. So literally you're allergic to, I don't know, ragweed, and giving you little tiny injections of ragweed to try to desensitize your body so that you aren't any longer allergic to that thing, or at least, I mean, you are technically, but it can be controlled by another aspect of your immune system. And let me explain what I mean by that. So this works pretty well, like it says, with things like plant allergens, venoms, dust mite, dander, moles, but not very well with foods. So the idea is we'll use the injectant to stimulate your body to make IgG against that allergen. And what will happen is the IgG will block the ability of the IgE on the mast cells to interact with the allergen. To be coated with IgG, now no longer can the mast cell with the IgE get involved. So that's the idea of how that works. So it doesn't necessarily make you no longer allergic. You're still allergic, but we're just controlling that response by desensitizing, by coating things with the actual IgG responsive antibody. So this is what's going on in these pictures up here. So we have block. So there's just different methods of how we can treat it, but we were just talking about desensitization, which is number 3. But we will have the altered form of the allergen, whatever. We've treated it a little bit differently. We give you in little bits and get you to produce IgG against that allergen. And then now we cover the allergen with IgG so that the IgE cannot interact with it anymore. No more allergy. That's desensitization. We can also block the events in the allergy. So this would be preventing IgE production, or it would be preventing degranulation of the mast cell. We also have monoclonal antibodies down here, which are specifically designed to keep IgE from the mast cells, to block them so they can't do their job and get associated with it. Then we have antihistamines and stuff like that that are just going to counteract the effect on the cells. And then, of course, avoiding the allergen is one way. It's one way to do it, right? So notifying medical folks, caregivers, that you have allergies to things like penicillin is extremely important. All right, moving on to type 2. This is type 2, talking about the blood groups here. So on red blood cells, we have what they call alloantigens. So they're antigens, those sugar-based antigens that are sort of identifying for 3 different types, okay? A, B, or O. So essentially O means that you would have just the basic version. A, you have the basic version bound with the A version. And then B, you have the basic version bound with the, B version, okay? So this will be A, this will be B, whatever. And so you're probably looking at this and being like, what about AB? Well, AB means that you have both the A and the B on there, not like mixed up on top of each other. Like you have both of them on the surface, okay? So that's important to understand this part to get to understand the next parts, okay? It's important to match up the blood types that you would be getting and giving based on all of this stuff. Very crucial. So you can inherit an allele. You only get one allele from each parent. So you can have an A allele, a B allele, or an O allele. If you've got a parent like I do who is B positive, and my mom is A something, I don't know what, probably, but she's never been tested, she says. So my dad would give me let's say a O. So he might have genes from his mom that was his dad gave him a B and his mom gave him an O, but this will express as B. So if I got that O from him and from my mom, who is, I don't know, A, let's just say she's AO, and I get her A, what am I going to express as? A. Because the O is just the base one. So if you also have the gene for the non-base, you're going to have the non-base on there, right? So in this case, this gene is A version of it. So O is always just like the blank, okay? O is the blank. So if you have anything else, it gets expressed. O does not. It is like recessive, okay? So if you are AA genotype or an AO genotype, like we just talked about up here, then you will express as A, and etc. Okay, so BB and BO, the O doesn't really count for much of anything. So it's a B. Now look, if you have an A from one parent and a B from the other parent, which my sister does, she's AB. So she has a type AB. You express both the A and the B. So if you're only whenever you're OO, will you actually see that you're O? Not when you're AO, not when you're BO, only when you're OO will you express it as OO, okay? All right, so those are the types. However, the problem is if I am an A and I have A on the outside of this antigen that is present on the erythrocyte membrane. So what's on my red cell is the same essentially as my blood type, okay? So I'm an A. So because I'm an A and I've never seen B before, it doesn't go in my body. That's not, no, that looks weird to my body. I look at it and I'm like, that doesn't belong here. So I have anti-B antibodies in my plasma. You see how this is starting to be a problem? Okay, so if you have a B blood type and you're expressing B on your cells, you will have anti-A because you've never seen A. That's foreign to you. You would attack it. If you are AB, however, you have A and B on your surface, both of them. So your body sees A as fine. It sees B as fine. What does it see O as? It's fine because that's nothing. That's the blank. Okay. So O, always fine. O, always fine. Don't question it. It's like the blank that everybody else is set up on. So AB, because it has A and B, it doesn't see either A or B as foreign. It sees them both as self. So we don't have antibodies to A. We don't have antibodies to B. We just don't have antibodies to O. Nobody has that. That's not a real thing. So yes. So now we have O. This is the problem. O is basic. It's the blank, right? It does not have A or B. So the problem here is that whenever it sees A or B, both of those are foreign to it. It will attack both of them. So it has antibodies against both A and B. This is important because this is what's going to delineate what kind of blood type you can receive as well. Because if you have anti-B antibodies like the A's do, like I do, and you give me B blood, my body will attack it. You can't give me B blood. That B's. If you do the same thing with the B's and you give them A blood, they will attack the A blood. The ABs, you can give them anything. They are called the universal recipient, and they can receive freaking any blood type. They're good. The O's can only receive O because they'll attack A or B. So if you give them A blood type or B blood type or AB blood type, they'll attack those. Only give them O. However, what have I told you about O? I told you that it is the basic one, right? I've already explained, I just went on and on about how, oh, don't worry about it. It's fine. It's always fine. So which blood types can you give O to? Well, it's not on this list with the antibody part because everybody can get it. You can't anti-O because it's part of the normal. It's the basic. It's the start. It's the baseline. So anybody can get O. But if you're O, you can only get O. AB can get any blood type, A or B or AB or O. Oh my gosh, they can get anything, the universal recipient, right? They can only give blood to AB. Nobody else can get AB blood. Kind of funny how that works out. Okay, so all right, so this is just a depiction, drawing you more pictures of it to help you understand that. I just explained it, but whatever. And when we do blood typing in hospitals, they have these cards that they can do it with, but essentially they mix blood, your actual blood cells, red blood cells, and mix it with these anti-sera like anti-A or anti-B, whatever. And based on whether it coagulates or not, if you give it anti-A and it coagulates, well, that means that the anti-A caused the A to respond. So that means it's an A. So like here, right? This one, anti-A. It coagulated. That's what this means. It clumped together. Agglutination. That's what the word is, better than coagulate. It agglutinated. They stuck together, the cells did, because the antibodies are making them stick together. So if the anti-A's are causing the cells to stick together, then you have A, because it's binding to the cells. And that's what that is. That's what's going on. And so you can determine blood type based on this and go all the way down and look at all of these. This one had A and it had B. When they mixed it with RH factor, which is the plus or the minus, it did not agglutinate. So there's no reaction. There's no anti-RH factor. And so this one's AB negative. Okay, so in universal transfusions, type O blood is the universal donor, and type AB, because they aren't going to attack anything, they can get anything. So they're the universal recipient. So remember that. This will be given in emergencies or in battlefield situations where we can't type you will just be given O neg. That's the universal donor. Okay. If we give you the wrong blood type, essentially your body is going to trigger the complement cascade against antibodies against the blood type. So you have I am an A, right? I have an anti-B antibodies. You give me B blood, then my body's going to attack it with my antibodies. The complement cascade reacts to that, the classical pathway of the complement cascade, right? And that leads to poking holes in those red cells due to that membrane attack complex. And then those red cells that I just received will get lysed open, broken open by those. The red blood cells that are being broken open, now we have all these red blood cells that are dead and floating around. That can lead to a systemic shock because the whole body is recognizing what's going on, and to the whole body that is like messed up. So it starts reacting appropriately, and then the kidneys will fail due to all the products and the chemicals being released associated with reacting to the broken down cells, as well as the actual broken down cells themselves. So death is common whenever you mix up a blood type. Okay. There's other symptoms, I guess they say, fever, anemia, jaundice, it'll be happening before you died. So you would want to halt the transfusion. And what is read it? And administer drugs that will help remove the hemoglobin from the blood so that that hopefully dampen the shock effect. There's not going to be a whole lot that can be done though. So RH factor, they also call it the D antigen. This is a positive or the negative. Positive is a dominant thing. So you can have a gene from your mom that is a positive and a gene from your dad that is a negative. And then when you have one of each, the positive is what's expressed. So your cells will be considered positive. Okay. They're dominant. They're going to be expressed over the negative. It's like what we saw with the O's, right? So the O's would be like the negatives here. And it's sort of the same situation because negative is the baseline again. So anybody can get the negative version of their blood type. So I can get A positive because I'm A positive, but I can also get A negative because I'm A positive, and my body's not going to, doesn't see anything weird about that. Just is the baseline. So that's important to remember as well. All right, so we're going to talk about hemolytic disease of the newborn. Essentially, you're a mom, you have a baby that is RH positive. Let's say you're RH negative. Okay, I don't even know, O neg. Your blood type is going to be O negative. Okay, you get pregnant with a RH positive fetus. Okay, so this baby has RH factor. The mother is going to, or you, I guess is in the analogy, but the mother will create antibodies against the RH plus. The RH, she's not ever seen RH plus. She's RH negative. RH plus is weird to her. So her body is going to react against it because it's a bad thing. It's foreign to it. But this happens later in pregnancy whenever we have development of the actual blood of the baby. It takes time, and then it takes time to actually build up a reaction to it as well. So we don't see any effects in the first pregnancy. However, in your subsequent Rh positive babies, we now have antibody already built up against this baby. The unfortunate thing is, I told you that the bloodstream doesn't form, and the blood that we're reacting to with the Rh positive on it that we see as alien, as foreign, it doesn't, it's not going to be made until later in the pregnancy. So unfortunately, you will grow your baby up quite a lot and pretty significant into the pregnancy. And then the mother's body will activate those antibodies that she made against the first Rh positive fetus that took so long that she didn't even know. And now the second one, as soon as it starts making blood, as soon as that starts happening, we can start attacking the baby with those antibodies that we already saved up from the last one. And going to take no time at that point. So this often leads to, well, this is what they call hemolytic disease of the newborn. It is very commonly deadly. This still happens today in this world. This is why we use Rogam. We'll treat the mother with Rogam, which has anti-Rh immunoglobulins to block up all that whole response so that the mother doesn't cause damage to the baby. So that's basically how that would work. Sort of like the desensitization with the allergens. So moving on to type 3, this is immune complexes. Essentially, we have antibodies that are sort of binding up with antigen. And we can see here, the little blue guys are the antigen, and these purple guys are the antibody. And you know, getting all these little mess formed up with these guys interacting with and across from one another and blah, blah, blah. They build up these big complexes. Bigger ones are going to be disposed of by the body, but whenever they aren't, what happens is they get lodged in the basement membrane of the epithelium. So this will happen often in the kidney, lungs, the joints, and the skin. And then what happens is neutrophils will so we can have, right, so this is talking about complement. You can have complement get associated here and the release of certain chemicals that'll be associated with inflammation. But we also have neutrophils that'll come along and degranulate, releasing enzymes in reaction to the antigen and the antibody complexing there together and getting stuck in that membrane. This can cause damage to the tissue and the organs eventually. So in type 3, it can be IgG, IgM, or IgA, more commonly IgE, and not really. That's what we were considering for type 1, right? The allergies. But so it can involve any of these. It just depends on what the reaction, what happened to cause this to build up, right? So, and this will require a large dose of antigen in order to stimulate this response. Whereas when we talk about anaphylaxis in type 1, this will require small dose. So that's a comparison as well. And we have a little bit of a delay in the symptoms. So not immediate, like what we see in allergies. This will be a few hours to a few days. So an example they're giving us here is acute post-streptococcal glomerulonephritis. That is a word, man. So this again is a classic type 3 mediated condition. We have a set of symptoms developed sometime after an infection with strep pyogenes, group A strep, okay? So strep pyogenes associated with sore throat, impetigo, necrotizing fasciitis. So I doubt that this is your problem, but it's more common to be like scarlet fever. It's more common to be strep throat. So group A strep will cause disease, whatever. Then complexes of antibody with streptococcal antigens that are all mixed up, making that big complex like we were showing in the other thing. This part up here. Okay, this will start to form that complex, and that'll settle in the basement membrane on the glomeruli in the kidney. That's an aspect of the kidney, okay? And then complement gets activated and neutrophils come in and degranulate, and we have damage to the kidney as a result. Glomerulonephritis. Nephritis is inflammation in the kidney. All right, type 4 hypersensitivities. Type 4 hypersensitivities usually involve T cells. This is cell-mediated response. So it takes a little bit, takes 2 to 3 days in order for it to appear. This is, like I said, delayed. So a classic example is whenever we give you that PPD injection in the skin to check for tuberculosis. So that injection that they give you, they inject it, they have you come back in 24 to 48 hours and to look at the inflammation, because within that time you should have had an inflammatory response if you had been exposed and reacted to Mycobacterium tuberculosis. That is a cell-mediated delayed type hypersensitivity response if you do have that. Okay, so that can happen with other microbes as well, by the way. It's not only going to be tuberculosis. Then we have contact dermatitis. This is also a type 4. We have resins in the poison ivy or poison oak. And this also includes haptens that are like in jewelry and stuff like that when you're allergic to metals and elastics. I had a big issue with that for a little while. It was weird. I don't wear them anymore, but yeah. Certain drugs we have it requires a sensitizing dose for all of this to happen. And then there's a provocative dose. So that means like originally you had to see this, you didn't react because you had to build up the cells, right? Later on, you see it again. That's the provocative dose. Okay. Sensitizing dose, you didn't see a response or you saw a small one. The provocative dose, that's the one that you're really going to start seeing that poison ivy rash or something. My ex-husband was not allergic to poison ivy at all, which was not good because he'd bring it in. Okay, so this is just talking about the process that's involved in that whole response. I'm not going to go through this, but it does give a little bit of a layout of what will be going on with those T cells in response to all of this. Yeah, so we've got our little T helper cells and our memory cell. That was our T helper cell coming along, interacting with the antigen that it recognizes from that dendritic cell, starts producing things like TNF, tumor necrosis factor, and interferon to help stimulate the inflammatory response and activate macrophages to go back to that area and fight off this terrible, horrible invader that we call, poison ivy. Then same thing, we have response from the CD8 T cells as well to go and actually kill our own T cells that have the oil or whatever stuck to it. So it's great. All right. We have type 4 reactions are what's involved in rejecting tissue grafts. This essentially has to deal with the MHC or HLA, same thing, surface markers. My surface markers look different from your surface markers. And so if I put my cells into you, immediately your body would see your MHC molecules, which normally would react with MHC molecules. It sees it as something it should react with, but then when it tries to react with it, sees it as foreign immediately as though you were presenting antigen, when really I'm just chilling existing. So that's what's going on. We will attack somebody's cells whenever their MHC molecules look different, and the less related you are, typically, the less similar your MHC complex is, typically. So this is just going over host versus graft and graft versus host. So when the host versus graft, that's the host attacking the graft, host versus the graft. So you give me a kidney that doesn't match. We have a different MHC1 molecule than what we're used to seeing. We see this as foreign. So what we do is we activate our response. So here's our T helper cell releasing cytokines to our call to action chemicals, and then that activates the macrophage, and now we're going to start attacking the kidney. So the cells that are actually typically involved in the killing here are going to be the macrophages, but everything has its little response here, because even our cytotoxic T cell up here, when it sees this as foreign, will do its granzyme perforin thing. So this is all bad. So our body's just straight up attacking that new kidney as just bad, 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 constant. And it can happen very quickly. You can actually see it happen in some individuals if somebody has a significant enough response. So graft versus host, you get bone marrow. And remember what's in bone marrow? The precursors to our B and T cells. So our lymphocytes, right? So it has lymphocytes hanging out. We have passenger lymphocytes from the graft. They come out and here they are, and they're like in our little body, and they're like, wait, They interact with these guys and they're like, wait, you are not right. You don't match us at all. And then, initiates an attack against the host's cells. So that's why matching is so important in these grafts. So we have 4 different kinds of grafts you can get via transplant: the autograft, isograft, allograft, and xenograft. The autograft, this is whenever we have tissue that'll be transplanted from one site on an individual's body to another site on that person's body. The isograft, this is whenever we have twins. Allografts, this is between 2 genetically different people, just completely different people. And xenograft is coming from a different species, like pig valves for hearts. All right, transplantation, we have organs like skin, liver, heart, kidney, coronary artery, cornea, and bone marrow. I worked in the Transplant Institute at Integris, and I did all the testing for all of this, all the matching. And we got quite a few. We didn't do the livers at our location because they were not as difficult to type. So we did the more difficult stuff. So we had hearts and we had kidneys and we had lungs. So we did get lungs occasionally, but they were not common and there was a lot more involved in it. Because typically with the lungs, you're dealing with cystic fibrosis. So it's usually who's receiving it. A lot of times the tissue is going to be coming from, it can come from living donors, right? So you can give a kidney to somebody as a living person or part of your liver. Recently deceased people, often on life support, but brain dead, and then fetal tissues as well, discarded fetal tissues. Autoimmune diseases. So all of these can be associated in one way or another. We're not really type 1, but type 2, 3, or 4 are often associated with autoimmune diseases, where these reactions are happening against our own body. We're seeing our own body as not self, as foreign, and that's not what it should be doing, right? There's more than 80 recognized autoimmune diseases. They can be systemic. So we have inflammation going on all over the body, reacting all over the body, or they can be organ specific, so local. So here are a few of them. Here's our little table of the diseases themselves, as well as characteristics associated with them, and important to you guys, the type of hypersensitivity that is involved here, as well as the tissue target, okay? All right, moving on to origins of the autoimmune disease. We can have a very common one is molecular mimicry, where the microbial antigens, like the bacterial surface markers, they look similar to our human cells. And so whenever they form antibodies against the microbe, when our body forms antibodies against a microbe, that also can cross-react with our own tissues. This is what we see in rheumatic fever and psoriasis to some degree. Infection. Here we have straight up infection, right? Type 1 diabetes and multiple sclerosis seem to be associated with this, possibly triggered by a viral infection of some kind. I think they're saying they think it's mumps, but I'm not sure. Don't quote me on that. The virus can alter the actual human cell receptor. So being infected, this is not the same thing as molecular mimicry. It doesn't look like us, but the virus is changing our own surface of our cells so that it doesn't look like self anymore to us. So then we attack that. All right, next we have the gut microbiome. It seems to be associated with a lot of our aspects of health, but due to antibiotic use, less exposure to the outside, and altered diet, it seems like we've had a major change in our gut biome. So that can distribute, and how we perceive things is often trained by our gut exposure, like what we have in our biome. So that can significantly alter how we would respond to things typically if we'd had considered like a healthy biome and proper exposure to certain microbes. So systemic autoimmunities, this one is systemic lupus erythematous. I can't ever say these words, but here you go, SLE, this is lupus. So we have that butterfly rash across the nose and cheeks where we have built up of the complexes, the immune complexes, right? They have autoantibodies against a lot of organs and cells. And this is going to cause kidney failure, blood abnormalities, lung inflammation, myocarditis, and skin lesions associated with this autoimmune disease. Another systemic autoimmune disease is rheumatoid arthritis. It causes progressive debilitating damage to joints. In some patients, lung, skin, eyes, and nervous system can also be affected. So not just the joints, especially if it is allowed to progress without treatment and abatement of the inflammatory response. Autoantibodies form immune complexes, again, that, we have binding into membranes that are going to cause release of granules and production of cytokines and, inflammation as a result. All right, Graves' disease is a local organ-based one. So this is an endocrine gland where we have attack on the thyroid gland itself. When we attack the receptors on that thyroxine secreting follicle cells of the thyroid gland, those thyroid cells, it causes the thyroid to release more thyroxine, and that is going to cause hyperthyroidism. So that can affect eventually every body system as a result of that, but the actual immune response is going on in just the endocrine gland. Another endocrine gland one is type 1 diabetes. This is a good one to be aware of. So insulin is secreted by beta cells in the pancreas, and that is what regulates glucose utilization, which I'm sure you can imagine is very important because we talked about energy production, right? So it is very important. So molecular mimicry is implicated in the sensitization of cytotoxic T cells. Inappropriate immune response will lead to the lysis or breaking open of the pancreatic cells. So, all right, and then we have neuromuscular autoimmunities, including multiple sclerosis, where we have paralyzing neuromuscular disease in the myelin sheath, a covering of the nerves. But essentially, we have T cell and autoantibody caused damage to those areas, and that causes damage to the nerve's ability to send impulses, resulting in muscle weakness, tremors, difficulties in speech and vision, and sometimes paralysis is associated as the disease progresses, the autoimmune disease progresses. We can see this as early as young adulthood. Some people have this a little bit later in adulthood. We think this is associated with human herpes virus 6 infection. So let's move on to the immunodeficiencies. These are going to be primary or secondary. Primary, that just means it was there from birth, from genetic errors. And then secondary, we have immunodeficiency diseases that are acquired at birth, or sorry, after birth, due to some sort of exposure to something like an artificial agent or a virus, typically, right? So let's start with the primary. Primary can be any one of these. Severe combined immunodeficiency over here. This is X-linked severe combined immunodeficiency. So that means it's associated with the X chromosome. It is a recessive gene. So this is typically, we only see this in males. But we do see this bubble boy here, bubble boy with SCID, okay? DeGeorge syndrome, at this point, it's just showing you at the point in the immune cycle that this would affect. So that you don't actually get proper maturation in the thymus here. And there's all sorts, congenital A-gamma globulinemia, so that you eventually can't produce antibodies in response to things. All of this obviously is going to cause severe issues in your ability to fight infections. In severe combined immunodeficiency, you can have like a zero immune system at all. So starting with gamma globulinemia, yes. This has to do with B cell development or expression of some kind. So there's a few different versions of this, but essentially you don't have gamma globulin, you don't have immunoglobulin, you can't make your antibodies. So hypogammaglobulinemia, because there can sometimes be some production of these guys, so they would just call it hypo instead of just complete A-gammaglobulinemia. We're not going to talk about it that way, though. Their T cell function is normal. They're not producing antibodies like normal, though. That part's bad. So they will have recurrent bacterial infections and viruses and protozoa, depending on how bad they have it. In T cell development, genetic deficit in T cell development will result in severe opportunistic infections, wasting away, and cancer. This is not surprising. What else do we see this in? AIDS. So this is the same thing. We're having a depletion of T cells in AIDS to the point that you have these other things happen. So not surprising that these symptoms are being seen here. If you have a genetic, essentially, version of it, so this can be more devastating than a B cell line. issue. So because you need the T helper cells, right? This is DeGeorge syndrome, where you have abnormal development of the thymus and therefore inappropriate development of the T cells. So you might have a severe reduced T cell production. So it's characterized by lack of cell-mediated immunity. People are susceptible to fungi, protozoa, viruses. Vaccinations with live attenuated, which aren't uncommon, can actually be very severe problem for them. And then we have normal childhood infections can be fatal to them as well. All right, SCID. This is going to involve dysfunction in both lymphocyte systems, Bs and Ts. Both of them are going to be severely compromised. Some are due to complete absence of lymphocytes. So that, of course, is really bad. Others are attributed to dysfunction of B cells and T cells later in development. So that's not quite as severe. Most infants will manifest symptoms within days after birth if they do have severe combined immunodeficiency. So secondary immune deficiencies, here we're talking about B and T cell responses being disrupted by infection or non-infectious metabolic diseases, or chemotherapy or radiation. So we'll start with AIDS. Of course, that's the obvious one. Yeah, so this is, of course, caused by HIV infection, so human immunodeficiency virus. And as that disease progresses and we have infection of T cells, then we have loss of T cells as a result. And to a certain point, once the T cell numbers will decrease to that certain point, then we have development of AIDS as a result. So it just depends on how few T cells you have at that point. So the T helper cells, the monocytes and the macrophages and all of the antigen presenting cells altogether are going to be infected with HIV. So B cells are included in that because they are also antigen presenting cells. Depletion of the T helper cells and functional impairment of the immune response will account for cancers, opportunistic infections, and can also lead to development of certain, I already said cancers, sorry, but yeah, opportunistic infections and cancers. And we know wasting away is associated with this as well. Cancers themselves, separate completely from HIV here and AIDS, cancer themselves can lead to problems with the immune system. So leukemia, here we have massive numbers of cancer cells that will displace normal cells in the bone marrow and the blood. And then we have leukocytes, that just refers to all the white blood cells. So then we have plasma cell tumors, where we have massive amounts of non-functional antibodies being made. That's going to make it impossible for you to make the proper things. And then the thymus tumors, that can cause severe T cell deficiencies, similar concept here. So all of those cancers, of course, treatment with radiation for other kinds of treatment. If you have a different kind of cancer that is non-immune system related, and you go get radiation treatment, it's going to be very detrimental to your health, your immune system. That's what I'm trying to say. So that was it for this chapter. I want you guys to answer me this question. How are type 1, 2, and 3 hypersensitivities similar, and how are they different? And I will see you guys for the next one. Thanks. Can't click.